This is a case presentation for atypical odontalgia. 41 years old male, his chief complaint 15 months history of pain in maxillary left canine and premolar. He had root canal twice in the tooth and even episectomy, and pain is still there. Now he feels continuous dull aching pain and occasionally sharp shooting pain in the tooth and gingival burning sensation over the anterior teeth when he touches the tooth or drinks any water. The medical history: he has chronic headache pain and anxiety, depression, insomnia. Upon exam, right side, the deep master has none, superficial none, temporalis none, condyle none. Left side, the deep master has moderate pain, superficial mild pain, temporalis has severe pain, condyle none. His opening 45 millimeter maximum opening, right lateral 11, left lateral. What is the assessment and diagnosis? Patient complains of constant pain in the left maxillary first premolar area, and pain keep coming back after few weeks of each treatment. Differentiation probably is accounting for the pain after root canal, and the most likely diagnosis for the constant pain is atypical odontalgia. The burning pain of gingiva could be due to traumatic neuroma as a result of nociceptor sensitization and sympathetically maintained. What is atypical odontalgia? Atypical odontalgia, also termed phantom tooth pain, psychogenic toothache, or persistent dentoalveolar pain disorder. It is a pain without known cause. It could considered as craniofacial pain or orofacial pain. Signs and symptoms: increased temperature and tenderness of the mucosa in the affected area, paresthesia, pain or throbbing. Pain is poorly localized but usually located in the region of maxilla, usually unilaterally. Sometimes located in tooth that has been extracted or associated with a previous surgical procedure, usually continuous with intermittent periods of increased pain. Pain increases over time. Management: psychosocial interventions include cognitive behavior therapy and biofeedback. Medications such as analgesics, antidepressant, centrally acting muscle relaxant, anticonvulsants. Also, surgical management. Surgery may give temporary remission from pain, but rarely is there a long-term cure achieved via these measures. Sometimes the pain may be increased or simply migrate to an adjacent area following a surgical procedure. Description of procedures such as removal of a portion of the affected branch of trigeminal nerve or direct injection of a caustic substance such as phenol, glycerol, or alcohol into the nerve have been reported. Proponents of the so-called neuralgia inducing cavitational necrosis suggest surgical exploration of the bone marrow surrounding the intra-bony course of the affected nerve to discover diseased marrow. So what happened to our patient? We started him on nortriptyline 10 milligram 1 hour before sleep for 3 days, and then increased the dose to 20 milligram after that. We took an impression for a stent. 2 weeks later, follow-up, patient reported his pain lessened by 30%, sleeps better, and his headache is lessened. We delivered the stent to use it with a combination of ketoprofen, ketamine, and lidocaine, and increased nortriptyline to 30 milligram. 2 weeks later, patient pain was lessened another 40%. We instructed him to continue to use the stent and increased the dose of nortriptyline to 40 milligram.